welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP-EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
Today we have Cecilia Schowe, who is a PGY2 EM resident at the U of L Health, and she will be presenting a journal club on assessment of high-dose acetylcysteine in acute high-risk paracetamol or acetaminophen ingestion. Thank you.
So just some objectives for today. We're going to recall the mechanism of acetaminophen toxicity and the rationale for increased doses of acetylcysteine in our massive overdoses. We're going to summarize some previous literature utilizing our high-dose acetylcysteine and our massive acetaminophen overdoses, and then finally evaluate a recently published article on this utilization of the high-dose acetylcysteine. So getting into our background, so acetaminophen overdose, it's consistently reported as one of the top causes of death by America's Poison Center. So this is something that we're consistently going to see within our healthcare systems and something that we need to be familiar with the treatment for this. So we talk about our toxic and our hepatotoxic doses in patients. Typically in our adult patients, this is going to be anywhere usually above about 7.5 grams. And then for a child, typically going to be 150 mg per kg. We talk about our hepatotoxic dose. For an adult, this is going to be 12 grams or greater or 150 mg per kg. And then our child, this is going to be anywhere from 200 to 300 mg per kg. When we talk about acetaminophen metabolism, so in our normal metabolism at normal doses, we get about 90% that goes through conjugation into our glucuronidine and sulfite moieties. And essentially, these are all non-toxic. We get about 5% that goes to the CYP2E pathway and produces NAPK. This is ultimately our toxic metabolite. In our normal setting of metabolism, we have enough glutathione that's produced by the liver that can help metabolize this NAPK into cysteine and our mercaptopuric acid that is then excreted as a non-toxic form. In the setting of acetaminophen metabolism during settings of toxicity, we have only about 70% that goes through conjugation into our non-toxic metabolite, and anywhere from 20 to 50% gets metabolized via CYP2E into our NAPK. So we have a lot larger proportion of a toxic metabolite than our non-toxic metabolite in settings of toxicity. And here, the amount of glutathione that our liver stores is not enough to metabolize all this toxic metabolite into our non-toxic form. And that's kind of where our NAT comes into play to help provide the cysteine to then produce enough glutathione to essentially neutralize all that excess NAPK that we're producing. So we talk about standard treatment for acetaminophen overdoses. And we have our Rumack-Matthew nomogram pictured here from our new consensus statement that was published last year. And most of our patients, we're going to get a Tylenol level that's drawn at 4 hours, and then it's going to be plotted on our Rumack-Matthew nomogram. Any patient that's essentially higher than this 150 mics per ml concentration line is when we would treat these patients. Talking about our NAC dosing and our standard overdose patients, we can either do oral dosing or IV dosing. Our oral dosing is going to be over 72 hours. Patients are going to get 140 mg per kg loading dose, and then are going to get 70 mg per kg every 4 hours maintenance dose. I think the oral is generally utilized less often than our IV dosing, given it's a lot longer duration, and then kind of the taste and smell for patients. So for our intravenous dosing, this is given over 21 hours. We give 150 mg per kg loading dose within that first hour, so essentially 150 mg per kg per hour. And then followed by our 50 mg per kg over 4 hours or 12.5 mg per kg per hour. And then finally, for our third bag, we do 100 mg per kg over 16 hours or 6.25 mg per kg per hour. So exponentially lower amounts as we go throughout that 21 hours. I noticed some hospital systems and poison controls recommend either a 2-bag versus 3-bag regimen. We're not going to really talk about the differences here on that today, but just knowing that your amount of NAC is decreasing as you go over those 21 hours. So we talk about massive acetaminophen overdose. Previously, before our consensus statement was published last year, we didn't necessarily have a standard definition of massive overdose. There's been a variety of definitions that have previously existed in the literature. Some of these were based on amount, so anywhere from over 30 to 50 grams or over 30 grams when co-administered with an opioid or antimuscarinic agent. And then there's also been some definitions of massive overdose based on your concentration at 4 hours. So whether it was greater than that 250 or even 500 mark. When the new consensus statements were published last year, they gave us a definition for massive overdose. It's a little bit more well established. So they define this as any acetaminophen ingestion over 30 grams, or just simply someone that has greater than 300 mics per ml on the Rumac-Matthew nomogram. So we talk about high-dose NAC. Regimens that have been proposed, we'll kind of talk about how this regimen came to be. But the picture here just kind of shows, based on the Rumac-Matthew nomogram and how high the level is kind of the exponentially increased doses that we'll give. So patients that are above that 150 line will get our standard dose. Greater than 300, we'll get that 12.5 mg per kg dose, or essentially we double bag 3 to 200 mg per kg over that 16 hours. Greater than 300, they get the 18.75 mg per kg per hour, or that third bag should be 300 mg per kg over 16 hours. And then finally, if you're over the 600 line, I'm recommending that 400 mg per kg over 16 hours, or that equates to that 25 mg per kg per hour. The dosing regimen that's proposed here is done by doubling bag 3. As we'll talk about with our study, there is some data to suggest potentially doubling it earlier, like in that bag 2. So who needs high-dose NAC? Previous literature has suggested that patients, even if they're treated within 8 hours with NAC, we're at an increased risk of hepatic injury, so an ALT greater than 150, or hepatotoxicity, or an ALT greater than 1,000. One study looked at patients with acetaminophen concentrations exponentially and then looked at their risk of hepatotoxicity. And what they found is once patients got over that 300 line, the rates of hepatotoxicity seemed to increase. So patients over 300 have anywhere from a 7 to 13% risk of hepatotoxicity, and then over 500 with about a 31 to 33% chance. So really patients over that 300 line start to see that increased risk. So why high-dose NAC, and why do we potentially need these higher doses? So ideally, NAC should be supplied in a 1-to-1 molar ratio with NAPQ that's produced to help supply enough cysteine to essentially produce enough glutathione to neutralize all that toxic NAPQ. The original dosing for NAC that we have that was proposed at 6.25 mg per kg per hour for that 3 bag was based on a 15.9 gram acetaminophen overdose, so not what we would consider our massive overdose, suggesting that maybe higher doses are required for some of these higher ingestions. Essentially, there was a pharmacokinetic model that was done, and that's where we got kind of our data for our high-dose NAC that we saw on the other side. And it was based on 9 different assumptions, included some of them here. So they assumed that the initial bolus of NAC is adequate for the majority of acetaminophen overdoses. It assumed that the amount of glutathione in the liver is null, so that patients have no glutathione to metabolize any of the NAPQ. Assumed a half-life of about 4 hours of acetaminophen, and then assumed that 25 to 50% of acetaminophen will become NAPQ after a massive overdose. And then finally, one of the last major ones is that no further absorption of acetaminophen will occur after that initial dose. So they used all these assumptions. These assumptions all kind of play on the safe side of dosing to kind of assume almost the worst and that we would need these higher doses. We'll talk about some of our studies have shown that maybe some of these initial assumptions aren't necessarily correct. So we look at our previous literature. One of the first studies looking at this is the ATOM2 trial done in 2017. And these looked at patients with ingestions over 40 grams of acetaminophen within 8 hours. And so they included 200 patients who had an average dose of 50 grams and a median time to presentation of about 3.5 hours. And then a median time to NAC administration of about 6.3 hours between groups. And what they found, 32% of patients received an increased dose of NAC, and this was most commonly done by doubling that third bag. So not all patients in this study received high-dose NAC. And what they were looking at for some of their results was incidence of hepatotoxicity. And what they found is an odds ratio of 0.27. And they showed that patients who had received increased NAC had a decreased risk of hepatotoxicity. Something else to point out, though, is that when they looked at patients developing hepatotoxicity, they had a longer time to treatment. So about 13.9 hours in patients who didn't develop hepatotoxicity or who did develop hepatotoxicity, and then 6 hours in patients who did not. Kind of a confounder there in this risk of hepatotoxicity. Some comments about this initial trial. It wasn't powered to assess differences in rates of hepatotoxicity between those who did and did not receive high-dose NAC. It was more just observational and looking at what they saw. There also was no formal dosing regimen that was evaluated. They said just most commonly that they doubled that third bag, but we don't necessarily know the dose and all the patients' paracetamol ratios and how high their levels were. So then in 2022, there was another study done that looked at acute ingestion of massive amounts of acetaminophen or greater than 300 mics per ml. And here they had 3 groups. They were looking at patients who received standard dose IV NAC, PO NAC, and then high dose IV NAC, which was similar to the dosing regimen that we talked about earlier. Here they had 373 patients. Did know a lower time since ingestion in the high dose NAC group with 8 hours in our IV standard dose, 10 hours in our PO, and then 10.5 hours in our high dose IV NAC. And they noted that 40% of patients received NAC within 8 hours of ingestion of acetaminophen. And what they found is, as far as high-dose NAC, they found no difference for the risk of the development of hepatotoxicity. But what they did find is that NAC treatment within 8 hours was a predictor for the development of hepatotoxicity, so patients that didn't receive NAC in time. So essentially, we have 2 studies here that kind of show differing results on this increased NAC and this risk for hepatotoxicity. So it's where our study comes in to provide some more literature into this, and is this high-dose NAC something that we need to be doing for patients? So that brings us to our study, the assessment of high-dose acetylcysteine and acute high-risk paracetamol or acetaminophen ingestions. So the purpose of the study was to evaluate patient outcomes after the administration of high-dose acetylcysteine following high-risk paracetamol overdoses. As far as their methods go, it was a retrospective chart review. It was done at a single poison control center in Utah, and it was done from January 1st of 2017 through December 31st of 2022. So as far as recommending high-dose NAC, so prior to 2020, PHIs would just occasionally recommend high-dose NAC when they consulted the toxicologist that was on call for patient-specific cases. But there was no standard of practice on who got high-dose NAC and when. And then after January of 2020, the poison control actually established guidelines on when they were to recommend high-dose acetylcysteine. And this was specifically for patients that had a level greater than 300 on the Rumac-Matthew nomogram. And then this didn't necessarily require consultation with the toxicologist. So it just gave them enough patients in each group to then kind of compare the differences. As far as dosing recommendations go, so this is what the Poison Control Center recommended following January of 2020. So every patient got the 150 mg per kg loading dose. And then their dose afterwards was based on their paracetamol concentration. So if it was greater than 300, they got a 20-hour infusion dose of 12.5 mg per kg, so doubled from our 6.25. If it was greater than 450, they got the 18.75, so tripled. And then greater than 600, they got the 25 mg per kg per hour, so quadrupled. Of note, this 20-hour infusion was done by either increasing the second and or third bag. It wasn't necessarily standardized for every patient. It was left up to the discretion of the treating physician. So potentially some patients could have been getting these higher doses with bag 2 and 3, compared to some patients could have only been getting these increased doses with bag 3 or about 5 hours into the treatment with acetylcysteine. So when looking at inclusion-exclusion criteria, they included all acute paracetamol exposures, which they defined as within 60 minutes of ingestion, and they included single and combination products. Patients had to have received IV acetylcysteine, and then their paracetamol concentration had to be drawn after at least 4 hours since ingestion, and then had to plot above the 300 line on the Rumac-Matthew nomogram. As far as exclusion criteria, they excluded patients with an unknown time of ingestion, those who had greater than 2-hour interruption in their acetylcysteine treatment, any sort of inconsistent acetylcysteine dosing. So if patients started on one regimen and then increased their dose, they were excluded. Any patient they excluded who they thought was originally acute and then turned out to be chronic, or vice versa, they would exclude. Any incomplete data, and then just finally, any elevation of AST or ALT at baseline that was likely confounded by alternative causes, so either rhabdomyolysis, ischemic liver injury, or just any non-paracetamol drug-induced liver injury. As far as outcomes, they didn't necessarily have any defined primary or secondary outcomes, but they were specifically looking at hepatotoxicity, which they defined as a peak AST or ALT greater than 1,000, and then any onset of liver failure, which they defined as hepatotoxicity with an INR greater than 2. As far as statistical analyses, they used a chi-square model for categorical data, Mann-Whitney U-test for continuous, and then for statistical significance, they reported this as an odds ratio with a 95% confidence interval, and this is reported for hepatotoxicity and or liver failure. They also performed some logistic regressions that we'll talk about at the end, specifically looking at age, gender, paracetamol ratio, elevations at presentation, and then how quickly patients got NAC, whether it was within 8 hours or not, and then just simply treatment with high-dose acetylcysteine and assessing these on their risk of hepatotoxicity. So as far as enrollment goes, they had 354 patients that were assessed for eligibility, with 155 being excluded. Most commonly, this was due to unknown time of ingestion, with 71 patients excluded for that. And then commonly inconsistent acetylcysteine dosing, greater than 24 hours of acetylcysteine treatment. So any patient that got an extended infusion, and then any acetylcysteine interruption were the other common exclusion criteria. So as far as their patient groups, they had 84 patients in the standard dose acetylcysteine group, and then 106 patients in our high dose acetylcysteine group. When looking at baseline characteristics, patients were on average about 18 years of age, and about 75% of patients were female. As far as co-ingestions go, there was no difference between groups. Relatively low number of patients that had opioids or anticholinergics also in their ingestion. What was statistically significant between groups was whether acetylcysteine was started less than 8 hours since ingestion. So about 54% of patients had it started less than 8 hours in our high-dose acetylcysteine group, and only about 37% had it started less than 8 hours in our standard dose group. When looking at some additional baseline characteristics, so AST, ALT elevation at baseline, so greater than 50, no difference between groups with about 20% of the overall population. They did find that patients were more likely to receive activated charcoal in our high-dose acetylcysteine group, with about 13% in that group. As far as acetylcysteine dose, in our standard group, all patients got our standard dosing, whereas in our high-dose group, they broke it down by what concentration patients got. So about 76% of patients got that 12.5 mg per kg per hour dose, with only about 12% and 11% getting our 18.75 and our 25 mg per kg per hour. And then of note, 2 patients in our high-dose group were given fomepizole, so different between groups, but not a high proportion of patients that were also given fomepizole. They also reported and stratified patients based on this paracetamol ratio. This is essentially used in a lot of acetaminophen research to just quantify patients, but essentially it looks at whatever their level is at, say, 4 hours, say it's 300. They compare that to whatever that corresponding concentration is on the 150 line. So if a patient at 4 hours has a 300 level, and then on the 150 line, that would be 150. So their paracetamol ratio would be 2. And this just helps to kind of stratify patients as you get concentrations at different time points. So you can kind of compare patients where they are compared to our standard dosing. And as you can see, most patients were within that 2 to 3 paracetamol ratio. So about 65% of patients in both groups. So as far as acetaminophen concentrations, so most patients, there was only one patient that had a level greater than 1,000, and their level is 1,096. Otherwise, most patients, the highest acetaminophen level was 625, with most patients falling between that time frame. This was just something they looked at. So looking at pre and post guideline implementation, trying to see where the trends were in patients that were consistently given high-dose NAC pre and post their guideline implementation in 2020. And really the biggest takeaway here is that patients that received high-dose NAC were more likely to be given high-dose NAC, the higher that their paracetamol ratio was. So like for patients greater than 2 to 3, only 27% got high-dose NAC pre-guideline, compared to almost 80% post-guideline. They were just more consistent and giving it to high-dose NAC in these like higher risk patient populations. As far as outcomes go, so when specifically looking at hepatotoxicity, they broke it down based on acetylcysteine started less than 8 hours, and then acetylcysteine started greater than 8 hours. When looking at acetylcysteine started less than 8 hours, there was very few patients that had any development of hepatotoxicity. Where this came into play was patients who had NAC started greater than 8 hours. And this was statistically significant between the groups. So more patients were more likely to get hepatotoxicity when NAC was started later in our high-dose acetylcysteine group. They then looked at paracetamol ratio and then AST, ALT elevation at presentation, and try to determine if any of those were the factors that potentially influence these patients having higher risk of hepatotoxicity, specifically in that acetylcysteine group that was started greater than 8 hours. And what they found is the only factor that influenced this was AST or ALT presentation at baseline, and patients were more likely to develop hepatotoxicity in those who had the AST, ALT elevation at baseline. As far as liver failure, patients that again had acetylcysteine started greater than 8 hours were more likely to develop liver failure in our high-dose acetylcysteine group, but they didn't find these differences based on paracetamol ratio or AST, ALT elevation specifically. In our subgroup analyses, they found no difference between groups. Just some additional outcomes and things to know is that no patients developed any anaphylactoid reactions in either a high dose or standard dose group. And then there was no liver transplants or death reported in any of these patients within this study. Again, they looked at this logistic regression, looking at risk factors for the development of hepatotoxicity. And what they found is that paracetamol ratio and then AST, ALT elevation at presentation, these patients are more likely to go on and develop hepatotoxicity, whereas patients who had acetylcysteine started less than 8 hours since ingestion, these patients were less likely to develop hepatotoxicity. And then high-dose acetylcysteine had no influence on the development of hepatotoxicity in these groups. So the authors concluded that high-dose acetylcysteine therapy did not decrease hepatotoxicity or liver failure in these patients. High-risk paracetamol ingestions compared to our standard therapy. They did note that elevated aminotransferase activity at presentation was most associated with hepatotoxicity, and then prompt treatment with acetylcysteine had the lowest odds of developing hepatotoxicity. So thinking about critique of this article, some strengths and limitations. So I think strengths was a relatively large sample size when thinking about toxicology studies. They had almost 200 patients total and relatively balanced baseline characteristics between groups as far as concomitant co-ingestions. And then really the only thing that was different between groups was how quickly patients got acetylcysteine, whether it was in that less than 8 hours. I also think definition of acute ingestion was a strength. So they specifically looked at patients who their ingestion was within 60 minutes. So focusing on a very specific patient population where we're more likely that that's when the ingestion occurred. And these patients have the best chance for a positive outcome, given that we can potentially get them acetylcysteine in that less than 8 hour time frame. I also think this data supports that an early initiation of acetylcysteine as a primary treatment, as what a lot of our other studies have shown, is that maybe not necessarily it's the dose of acetylcysteine that we're giving patients, but really that we're just getting them treatment in that less than 8 hour time frame. As far as limitations go, it was a retrospective study design and then a single poison center, potentially limiting generalizability to some of our patients. Potential selection bias with more severe patients, more likely to receive higher doses, especially in their pre-guideline implementation, although we didn't necessarily see that with differences in our baseline characteristics. Time of ingestion was also reliant on patient history and chart reviews. We just had to rely that patients were truthful with how long ago their ingestion occurred. And then there was a low number of patients who had this paracetamol ratio greater than 3, or just patients in general that got greater than that 18.75 mg per kg per hour dose. So really, I think this data kind of supports that patients between that 300 and 450 mark. I think generalizing it to those other massive ingestions greater than that 450 is a little bit harder. We didn't necessarily have a power calculation or any definition of our primary or secondary outcomes. There was also a large number of patients who received NAC greater than 8 hours after presentation. Again, this is probably more generalizable to what's potentially happening in a lot of health systems, but I think it can definitely be a limitation in that we can't necessarily compare patients who got it less than 8 hours and then is our high dose NAC really effective at that point. Also consistency in dosing. So particularly which bag was increased. So if patients got that increased dose of NAC right off the bat with the second bag, they were getting more NAC almost 4 hours earlier than potentially patients who only had it increased in that third bag. So I think just some final thoughts. So in any of these patients with our massive acetaminophen ingestions, these should really be made in conjunction with our poison control centers and our medical toxicologists, and should really be made on a case-by-case basis on patients who are going to benefit from these higher doses of NAC compared to those who, even if they have a massive ingestion, could potentially be treated with just our standard dose. I do think patients with massive acetaminophen overdoses may be able to be treated with just our standard dose NAC without necessarily increasing risk for hepatotoxicity, especially patients who are between that 300 and 450 mark and without any other necessary risk factors for increased risk of hepatotoxicity. So I think we should definitely look at patient-specific factors that may increase a patient's risk of hepatotoxicity. So type of acetaminophen product, age of the patient, any chronic alcohol ingestion or baseline liver dysfunction, and then potentially any co-ingestions. Taking into these factors when we're deciding whether to treat someone with high-dose or standard dose acetylcysteine. And then finally, I just think more studies are needed for patients who have these acetaminophen ratios greater than 3, and then those receiving NAC doses greater than 18.75, just because that wasn't really represented as well in this study. And with that, I'll take any questions.
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.